Hello, I'm Dr. Kevin Most, Vice President of Medical Affairs and Chief Medical Officer at Northwestern Medicine at Central DuPage Hospital. I also serve as the current chair for the American Hospital Association Committee on Clinical Leadership. I want to welcome you to the AHA's overview of upcoming physician payment changes, also known as MACRA. These changes have major implications for physicians, hospitals, and many others in the healthcare field. The AHA is committed to helping you prepare for these changes. The AHA has already made a number of tools and resources available to help all of us get up to speed on these changes. These are available at aha.org/MACRA. This webcast adds to that set of tools and is part of the series that the AHA is developing to help the hospital field prepare for these changes. To tell us more about the changes and what they mean for hospitals, I'm happy to be joined by two of AHA's policy experts, Akeem Demahan and Melissa Myers. Akeem, maybe we can start with you. Can you tell us how these changes came about?
Sure. These changes came about as a result of the Medicare Access and Chip Reauthorization Act of 2015, also known as MACRA. The MACRA does three important things. First and foremost, it repeals the sustainable growth rate model for physician payment. Each year, the SGR would have resulted in significant payment reductions to physicians without a patch, and for 18 years, patches were put into place to fix the SGR. So the SGR is no longer at play, and there are stable payment updates over time. The second important thing that the MACRA does is to establish a new two-track physician payment system. The first track of that payment system is known as the Merit-Based Incentive Payment System, or MIPS. The second track is known as the Alternative Payment Model track. Each of those tracks has differing payment incentives and amounts of payment at stake. But taken together, the MACRA really does a third important thing, and that is to really raise the expectation around delivering on quality and value, and it also incentivizes a movement towards new alternative payment models.
Melissa, that's a major change. So can you talk to us more about what hospitals and doctors need to be paying attention to?
Well, for physicians, the impact of the new MACRA law is fairly clear and straightforward. The law makes major changes to the way physicians are paid by Medicare. It ties a significant portion of their payment to risk based on their performance on specific metrics. And it also encourages them to move into alternative payment models. For hospitals and health systems, the impact is a little less obvious, but still significant. For example, those hospitals and health systems that are looking for opportunities to align with physicians might find them under the MACRA, as physicians are looking to their local hospital or health system for assistance, perhaps with the quality reporting requirements, and also to help stabilize their payments. Hospitals that are contracting with physicians will want to evaluate those contracts to determine if they would like to align the contracts with the incentives under the MACRA. And then finally, hospitals may want to explore risk-based alternative payment models to partner with local physicians and help them achieve the incentives that are built into the MACRA law.
When you talk about reporting quality data to CMS, physicians and hospitals are already doing that. How is this going to change? How is it different from what they're currently doing?
They are, and it is a really good question, and it is important to note that there is some overlap between the new physician payment system and the three previously separate payment systems. Right now, the three quality payment systems for physicians are the Physician Quality Reporting System, the Value-Based Payment Modifier, and the Meaningful Use Program for Individual Clinicians. What the MACRA does that is different is that it consolidates these programs into a single program. Some of the measures are the same as those used in existing law programs, but the scoring methodology is different. And what also makes the MACRA a little bit different is that the scoring methodology is consistent across categories.
Akeem, we know how much physicians love change. So can you tell us, what should the physicians expect? They want to know what changes to expect.
So there are two tracks under the MACRA, and I'll talk about the merit-based incentive payment system. The MIPS includes 4 categories of performance on which physicians and other eligible clinicians will be assessed. The first is quality, and the quality category includes the measures, some of the measures that are used in existing law programs. It also includes some new measures that CMS will add to the program. The second category is resource use. These are measures that are intended to reflect the amount of resource used by practices as well as their costs. Here, CMS can use the measures that it uses under the value modifier program. CMS also intends to expand that list to include some additional measures as well. The third category is a new one, and it's called the Clinical Practice Improvement Activity category. This is a category that's intended to recognize clinicians for participating in activities that improve patient safety, that improve care coordination, and that contribute to higher quality in their practices. And here, there will be a list of activities from which clinicians can select and receive credit towards that score. The last category is known as the Advancing Care Information category, or ACI. The ACI will look familiar to those who are well-versed in the Meaningful Use program for individual clinicians. What's different about this is that instead of being an all or none scoring approach, it's more of a continuous scoring approach where there's a base performance component in addition to the achievement of some performance objectives as well. Each of these categories under the MIPS has a weight towards a total performance score. For the first year, 2019, the quality category will be worth 60% of the score. The resource use or cost category will not be considered in the score. Clinical practice improvement activities will be worth 15% of the score, and the remaining 25% will go towards the new Advancing Care Information category.
Ken, can you talk a little bit more about the performance reporting?
Sure. So under each category, clinicians will need to report data. The way in which that data is reported will vary a little bit by category. For example, under the resource use category, there's no actual reporting required. CMS will use Medicare claims data to calculate performance. But for the quality category, the Advancing Care Information category, and the Clinical Practice Improvement Activity category, clinicians will be expected to submit data. The submission mechanisms are varied. For example, there are qualified clinical data registries, clinical registries, electronic health records. Those clinicians participating as individuals will be able to report data using special codes that are included on Medicare claims. But what's also important to note is that for each category, clinicians will be expected to select one reporting mechanism for each. Just to play that out, take the quality category, for example. A clinician would have to select the clinical registry category to report all of the measures in the category, and they couldn't, for example, mix together data reported from both an EHR and a clinical registry.
Thank you. You know, we know this is a quality and value-based change, so how exactly will it affect physicians' payment?
The MACRA really raises the financial stakes of performance on quality and on resource use. There is a certain percentage of payment at risk each year under the MACRA. It starts at 4% during the first calendar year, which is 2019, and it rises all the way to 9% in calendar year 2022 and beyond. And so that means there's an opportunity to earn both a upward payment adjustment of up to 9% as well as a potential payment penalty of up to 9%. In order to determine performance, CMS will combine performance on each of the 4 categories of the MIPS and calculate a total performance score. That score will range between 0 and 100 points. Each year, CMS will also establish a threshold above which clinicians will get positive payment adjustments and below which they'll get negative adjustments. those that score at only 25% of that total performance score will actually receive the maximum negative adjustment under the law. But those that do exceptionally well under the MIPS also will be eligible, in addition to that up to 9% payment adjustment. They'll also be eligible for what's known as an exceptional performance bonus. CMS has the ability to pay out up to $500 million per year in exceptional performance bonuses to clinicians. It is important to note, however, that those bonuses do go away after calendar year 2024.
Akeem, it sounds like we're talking about a lot of physicians that are seeing patients face-to-face. And yet we have many physicians that don't do that. We have pathologists, we have radiologists, that's how they practice medicine. How will it impact them?
Well, the answer is that the merit-based incentive payment system and the MACRA writ large does impact those clinicians as well. However, what the law provides is the ability for CMS to alter its scoring approach and its requirements under the MIPS to suit the unique practice situations of those clinicians. So, for example, CMS could choose to put a higher weight on particular activities within the clinical practice improvement activity category. They could choose to use a different weight for an entire category altogether. CMS will have to identify and have a mechanism to identify those clinicians that primarily provide patient care in a non-patient facing manner. And we expect to get more information about exactly how they'll define that soon.
So, Keen, another curveball for you. We have many providers that provide care in rural areas. They're not in suburban areas, they're not in urban areas. Will this impact them? Will it affect them the same way as it does all the physicians that are practicing in metropolitan areas?
That's a great question. And the short answer is it depends a little bit on the specific situation of those rural providers. Let me talk about critical access hospitals first. Critical access hospitals have two different billing methods, Method 1 billing and Method 2 billing. Those CAUs that use Method 1 billing are exempt from the payment provisions under the MACRA. Those that participate in Method 2 billing, and this is where the hospital has the ability to combine the billing for its clinicians as well as the billing that it does for its inpatient services. That actually depends on whether the physicians and other clinicians have reassigned their billing rights to the hospital. If they have, and they're billing under Method 2, then the MIPS actually does apply. However, for federally qualified health centers and for rural health clinics, the MIPS actually does not apply, and that's actually a statutory exclusion. The important thing to note here is that there are some subtle variations that depend a little bit on the particular billing situation that's being used by the particular rural provider. So let's say, for example, you have a provider that's working at a federally qualified health center and actually moonlights somewhere else where they're actually billing under the physician fee schedule. The portion of the services that they are providing and billing for under the billing system for federally qualified health centers, that actually is not subject to the MIPS at all. The services that they provide, however, under their kind of moonlighting arrangements, those actually could be subject to the MIPS. In addition, CMS will have to establish a minimum threshold below which the MIPS does not apply. So, for example, the MIPS may not apply if a clinician happens to bill for fewer than 100 Medicare patients and receives billing for less than $10,000 worth of Medicare services. That's a mechanism intended to recognize that not all clinicians have enough activity under the Medicare program to be scored in an accurate way.
Melissa, let's give Akeem a break for a couple minutes. He mentioned, though, about physicians who participate in the alternative payment models and that they could be exempt from this. Can you explain more about that to us?
Well, under the MACRA, only certain payment models count for purposes of the incentives. CMS calls those advanced alternative payment models. And to count for purposes of the incentives, these models have to meet 3 criteria that are set in law. The first is that the payment model has to require participants to use a certified EHR. The second is that the payment model has to tie some amount of payment to quality metrics that are comparable to those that are used in the MIPS quality reporting category. And then finally, and this is probably the most important determinant of whether a payment model will count as an advanced APM under the law, the model has to require that entities participating in the model, that is, that entity that is contracted with CMS, has to bear more than nominal risk for financial loss. And CMS is interpreting this to mean that under the payment model, for example, if the model incorporates a benchmark or a financial target, if the entity's Medicare spending under the model exceeds projections through the benchmark or target price, then the entity participating in the model must owe at least part of any losses back to Medicare. I will note that under these criteria, there are only a handful of current Medicare models that would meet these criteria, including Tracks 2 and Track 3 of the Medicare Shared Savings Program. Track 1 of the MSSP, which is a shared savings only model, would not qualify. Innovation Center models that would qualify are the Next Generation ACO, the two-sided risk track of the Oncology Care model, the Comprehensive ESRD model, and finally the Comprehensive Primary Care Plus model would qualify. The Comprehensive Care for Joint Replacement Bundle Payment Program would not qualify for 2017, but CMS has proposed an option to allow it to qualify going forward. Finally, CMS is exploring another ACO track, which it's calling the Track 1 Plus, which would be a model that would include downside risk, but to a more limited extent than the models currently available. This would allow another option for ACOs that are not yet ready to move on to a higher risk track. I'll also note that physicians that participate in these models have to meet certain thresholds for participation in order to qualify, and those thresholds are measured either by patient counts or by payment amounts through the payment model. CMS plans to assess this at the level of the actual entity that's participating in the model and that's contracted with the APM. So what CMS plans to do is to aggregate participation among all clinicians participating in the model through what's known as the APM entity and look if, on aggregate, the clinicians participating in the model meet those thresholds. Now, I will note that the thresholds are fairly aggressive. For example, when looking at payment amounts, the threshold starts out at 25% of Medicare payments going through the alternative payment model in 2019 and 2020. In 2021, that amount goes up to 50% for 2021 and 2022. And in 2023 and beyond, that goes up to 75% of payments going through alternative payment models. So again, those are fairly aggressive targets for participation. And I'll note that in 2019 and 2020, only Medicare fee-for-service alternative payment models will count. Starting in 2021, CMS can look across all payment models, so that will also include any arrangements through Medicare Advantage plans, but also through Medicaid and private payers.
So Melissa, as I listen to those criteria, and I'm sure others are listening as well, what happens if my payment model doesn't qualify? Or what if I don't have the volume necessary to qualify?
So the law actually includes some incentives for those clinicians who are participating significantly in alternative payment models, but don't quite meet the threshold set in law. Those clinicians are able to actually determine for themselves if they want to participate in the MIPS, if they want to report under the reporting requirements there, and also potentially be subjected to the payment adjustments that would occur under the MIPS. Now, for those organizations that are participating in payment models that don't meet the three criteria that I mentioned, that is the certified EHR criteria, the quality measurement criteria, and the financial risk criteria, those entities would be participating in models. CMS has created a category for them called MIPS APMs, and there are some more limited incentives for folks who are in the MIPS APMs, and I'll turn to Akeem to explain more about that.
Sure. So the MIPS APM category is one that allows for CMS to apply a different scoring methodology under the MIPS. As we talked about earlier, there are four categories under the MIPS. The quality category, the resource use category, the clinical practice and proven activity category, and the advancing care information category. What CMS has intended to do with the MIPS APM scoring approach is that it won't assess those participants in MIPS APMs under the resource use category. The reason for that is that the mechanism for calculating cost performance under these alternative payment models is actually quite different than the set of measures that one might use to assess resource use performance under the MIPS. And so CMS is going to zero that out and redistribute the remainder of the composite score to the other categories of the MIPS. So, for example, the amount allocated to the clinical practice improvement activity category goes up, as does the advancing care information category. It's a mechanism that's intended to provide some recognition of participation in those APMs and an effort to try to reduce potential mixed signals, especially in terms of calculating resource use performance.
And I'll just note that although in 2019 and 2020, Medicare will only be looking at alternative payment models that involve Medicare fee-for-service payments, starting in 2021, there will be the all-payer option that also includes Medicare Advantage, Medicaid arrangements, any private payer arrangements. And what CMS plans to do is first look at Medicare participation, and if a physician does not meet the thresholds for participation under Medicare fee-for-service arrangements, it will then look across all payers at any arrangements there.
We're trying to sort this out across the country. Physicians, hospitals, we're all trying to sort it out. You guys are obviously a wealth of information. But if I asked you, can you give us a couple of key takeaways that we should take today, what would they be?
I would say that each entity from a health system all the way down to a physician practice needs to really look at the two options available between the MIPS and the alternative APM track, and really evaluate which one works best for that entity. One consideration might be that while the alternative payment model track might look attractive because of that 5% bonus, that bonus actually drops out after the first 5 years. And in contrast, the amount at risk under the MIPS goes up to 9%, and that is in perpetuity. That potential bonus under that program does not go away. But at the same time, that program does come with some reporting requirements and also some potential downside.
The other thing that I would add to the list of sort of takeaway messages and things that hospitals, health systems, and physicians can start thinking about now. There are some choices that will have to be made with respect to what measures to report, what kinds of activities to participate in. And so beginning to think about how you would go about selecting quality measures, what reporting mechanism you might choose in order to submit those data to CMS. For example, you could think about if you're participating in the physician quality reporting system now, seeing whether using the existing reporting mechanism would be something that you want to continue doing. That would certainly be an important consideration. And also thinking about how to share data internal to the organization to drive improvement. At the end of the day, performance on the MIPS will be compared to others across the country. And so beginning to think about how you not only get the data in, but begin to use it to achieve greater performance and advance that through the organization is definitely something to begin thinking about now.
And then finally, I'll note, in addition to those considerations, for those organizations that are considering entering into advanced alternative payment models, they'll need to evaluate whether they're prepared to move into a new payment or care delivery model, including to accept downside risk.
Melissa Akeen, thank you for taking a very complex subject and laying it out as well as you did for us. And I'd like to thank you all today for listening. For more tools and resources on the new physician payment system under MACRA, please visit the AHA website at aha.org/MACRA.